Good evening, everyone. I welcome you to the webinar PPH Prevent the Catastrophe, organized by Jhansi Obs Gyn Society, Moradabad Obs Gyn Society, with FOGSI Young Talent Promotion Committee to join hands for Zero PPH World. On behalf of Jacksonpal Pharmaceuticals Limited, makers of Jepitone syrup, Cyclorex CR10, and Endorec tablet, I'm Dr. Vipin Tyagi, along with my teammate, Mr. Amit Saxena. We feel honored to have as chief guest, Dr. Alpesh Gandhi, President FOGSI. We thank you for gracing this webinar, sir. We are thankful to Dr. Archana Verma, Vice President-elect 2021 FOGSI, Pratik Tambe, Chairperson AMOGS, Endocrinology Committee, Governing Council member ICOG for organizing this webinar. We are thankful to ICOG for the accreditation of 1 ICOG point to all attendees of the webinar today. We thank all the esteemed chairpersons for sparing your valuable time to impart words of wisdom to all. Dr. Rajendra Nagarkatti, Chairperson, Midlife Management Committee, FOGSI. Dr. Neharika Malhotra, Chairperson, Young Talent Promotion Committee, FOGSI. Dr. Saba, Asad, Vice President, Moradabad Obs Gyn Society. To enlighten us on today's topic, we welcome speakers of the day, Dr. Asha, Jain, President, Raipur Obs Gyn Society, Dr. Jaydeep Tang, Secretary General FOGSI, Dr. Poonam Varma Shivkumar, Professor and Head Obs Gyn, MGIMS, Sevagram, Maharashtra. For today's discussion, we welcome the moderators, Dr. Alpesh Gandhi, Secretary, Jhansi Obs Gyn Society, Executive Member, ESOPAR West Zone, Dr. Sajia Monis, Consultant Obstetrician and Gynecologist, Infertility Specialist, Secretary, Moradabad Obs Gyn Society.
Vipin ji, aap itna ye detailing mat kariye, just tell the name also.
Okay. Welcome to all attendees. Please post your queries by text in Q&A box to be answered at the end. Please note this webinar is brought to you as knowledge sharing initiative by Jacksonpal Medical Services, and this session is streaming on Facebook Live. The recording will remain on Jacksonpal's YouTube channel for reference and promotion. I will now request Dr. Alpesh Gandhi ma'am to kindly initiate the session. Over to you, ma'am.
Thank you, Dr. Vipin. A very warm welcome to all the assembled dignitaries, faculties, and audience from Jhansi and Moradabad societies and YTP Committee FOGSI for this very important webinar on postpartum hemorrhage, Prevent the Catastrophe. Today is indeed a star-studded evening with all the stalwarts of FOGSI gathered on one platform. We are very fortunate to have the blessings of Dr. Alpesh Gandhi, our National FOGSI President, a great visionary and an ardent planner. We welcome you, sir. It's time now to welcome the conveners of today's webinar, Dr. Archana Verma, Vice President-elect 2021, and Dr. Pratik Tambe, Chairperson AMOGS Endocrinology Committee and ICOG Governing Council member. Dr. Archana Verma is very passionate about creating awareness on women's health. She is a Vice President-elect FOGSI 21, past President OBG Gyn Society Ghaziabad, Organizing Secretary of North Zone Yuva FOGSI 2016, UP ISA 2015, Midterm UP COG 2015. She is the Chairperson of Public Awareness Committee 2015 to 2018. She has various awards to her credit. To name a few, President FOGSI Best Committee Appreciation Award, which she very rightly deserves. India Book of Records for Walkathon. She created history on 1st January. She made us all walk around the roads. UP Governor, Uttarakhand Governor Appreciation Award for Menstrual Hygiene. Appreciation Award for CRPF Director of Health Programs 2019. Woman of the Year Health Award from IS Wives Association. She was faculty in more than 300 plus national and international CMEs. We are honored by your gracious presence. In fact, this webinar is your brainchild and the topic, and it is very meticulously planned. Please say a few words of blessings. Dr. Archana, ma'am, please.
Very good afternoon. Dr. Pratik, should we, I think, call Dr. Pratik and invite Dr. Alpesh Gandhi sir first. Dr. Pratik? Alka, please introduce Dr. Pratik.
Dr.
There's no need to
Shah,
introduce
please
me,
invite,
that's fine.
Dr. Pratik.
Dr. Archana, please continue.
Okay, sir. Thank you. Oh, thank you, sir. आपके सामने जरा बोलने में लग रहा था. Actually, the PPH is my passion, and I want to aware each and everybody about the main this as a great concern, and it is one of the, we all know, one of the major cause for MMR. And I have come today with a 10 points program to remember. First is all pregnancy are at risk. Don't forget that. Secondly, PPH often occurs without any warning signs, and we need to emphasize this very important point to all the even judiciary people also, because when the patient comes and do the medical legal problems and they say कि doctor ने उतना हमको inform नहीं किया, we were not informed, so that is a very important point. And third is a no pandit. Even no pandit can do the predictions for PPH, and only 1.5 to 2 hours time is there when the patient can succumb to hemorrhage. So it is our duty to prevent the famous delays in the treatment, like transport, calling ambulance, and calling pupil, and resuscitation. We all should be ready for the code blue at each and every stage. And number 5, think of PPH as tsunami, and we need to prepare our mind, our team, and our patient for all the possible therapies. They should be counseled very well throughout the 9 months, even the before. And number 6, when the patient, you are paramedical staff is taking blood pressures and telling you, and you are feeling happy that BP is well maintained, that don't be, this can be wrong, because BP is not a good indicator in case of PPH, and rather we should all have a habit of taking and noting the shock index. And shock index is a heart rate divided by the systolic blood pressure. So if you can early diagnose, because whenever there's this compensatory shock occurs inside, the BP remains normal, but there's a tachycardia. So if the shock index increases from 0.5 to 0.7, then it is a time to do the a possible resuscitation. Number 7 is learning the prevention. The AMTSL, that is active management of third stage of labor, actually it speeds up the uterine contraction and thus decreases the atony, which is a major cause for the PPH. And we should learn the mother-friendly deliveries. And secondly, we should remember that noting the PPH, it sometimes the small seepages can be equally dangerous from the episiotomy, and you are not even looking for them, and you are not noting it. And the blood clotting inside the uterine cavity, big clots can be there, but very less bleeding occurs outside. And so the patient and the paramedical staff can be unaware of the heavy bleeding. And number 9 is a major pitfall in the management of the PPH are the actual blood loss estimation. It is notoriously always inaccurate, and patients don't understand this issue of PPH. They think all the doctor's fault. They are not able to give, the doctors are not able to give proper injections just to control the bleeding. इनको पता ही नहीं है इंजेक्शन कौन सा देना है. इन्होंने कोई वेन काट दी अंदर की, इसी से ब्लीडिंग हो रही है. And at the primary health center, they expect the level 3 tertiary level management, and they want to just they can do only the mob violence. So we have to be well prepared for that. And third and last 10 number point is that remember quality care and updating your skills and paramedical trained staff and the resuscitation, and so that you predict and prevent and handle, that is a PPH, and there's a less of perspiration, less of panic, and more of happiness. Thank you very much.
Thank you, Dr. Archana, for the kind words. I call upon
today's speakers will do the best for this PPH management. We have all the stalwarts, and now the Dr. Pratik will say a few words.
Dr. Shajia, please introduce Dr. Pratik. Unmute yourself.
He's muted. That's fine. There's no need to stand on ceremony.
Thank you, Dr. Alka. A very good evening to all of you. It's an honor and a pleasure to welcome each one of you for being here and on this most awaited session, and that is on postpartum hemorrhage. And I'm sure this session is going to be packed with rousing speeches, thought-provoking cases, and a platform also to meet amazing people. And I'm sure it's going to be wrapped up with lots of carry home messages. We are very humbled and honored to have our eminent speakers and our FOGSI president, Dr. Alpesh Gandhi, sir. And I also thank Archana Verma, madam, for organizing such a wonderful program. Now, it's also my proud privilege to welcome our co-convener, Dr. Pratik Tambe, sir. He's the chairperson AMOGS Endocrine Society. He's a great academician and a source of inspiration for all of us with great academic record. He is the ART consultant and gynae endoscopic surgeon. He has done international diploma in advanced laparoscopic surgery from France. He's trained in assisted reproduction in Belgium. He's the chairperson AMOGS Endocrine Society. He's the governing council member ICOG. Sir has a long list of honors to his credit. And he's the chairperson FOGSI Endocrine Committee. He's the editor of 10 books, 3 FOGSI focuses, handbooks. He's a recipient of 15 MOGS and 7 FOGSI prizes and awards. We are very honored to have such an academic person with us. Welcome, sir.
Thank you, Dr. Shazia. Thank you for that lovely introduction. And without further ado, it's my proud privilege to introduce our chief guest for today, who's none other than the president of FOGSI, Dr. Alpesh Gandhi. Sir is the president of FOGSI at present, 2020-21. He's been the vice president of FOGSI in the past in 2013, a governing council member of ICOG 2016-17. In the past, he's been chairperson of the Practical Obstetrics Committee of FOGSI. He's the vice president of Gestosis India chapter, the past president of the Ahmedabad Society, past secretary of the same society. And of course, we all remember AICOG 2017, which was held at Ahmedabad. Sir was the convener for the same. He's also been the past joint convener of SOGOG in the past, and he's had so many academic distinctions. His primary work has been in the field of obstetric HDU and obstetric ICU care. His book on the principles of critical care in obstetrics is now available in more than 5,000 libraries all over the world. It's been translated into several languages, and sir has been one of the pioneering, I would say, forces for liaising with the government and encouraging more implementation of emergency obstetric care at the primary and secondary healthcare level. We are very privileged to have Dr. Alpesh Gandhi here, especially because this program is dedicated to postpartum hemorrhage and its ramifications.
सर एक लाइन तो मैं भी बोल दूं, पहले गांधी जी आए थे और अब ये हैं, पूरे तहलका मचा हुआ है पूरे फॉक्सी से लेके पूरे गवर्नमेंट में. एंड सो वी आर सो हैप्पी कि हमारे इतनी रिकॉग्नाइज हो रही है फॉक्सी.
Second father of nation.
Father of FOGSI.
कुछ तो बदल के जाते जाते फॉक्सी का नाम कुछ ना कुछ तो सेपरेट आना ही है.
Thank you, Archana, for your regards, but this is too much. I am nowhere. Mahatma Gandhi is.
आप देख लेना, यही लाइन सत्य होने वाली है लाइफ में चल के.
So, thank you, my friend Dr. Pratik and Dr. Archana, for the kind words, generous introduction, and for the invitation for this honor. I congratulate Jhansi Society, Moradabad Society, Young Talent Promotion Committee, FOGSI, for organizing this webinar, very, very important for all of us to learn, to update about PPH. Today, we all know that about 830 women die from pregnancy related complication around the world every day. And out of this, 52% maternal deaths are attributable to 3 leading preventable causes. We can say most of them are preventable, though always it may not be preventable, but in majority of the time, they are preventable. So first is hemorrhage, second is sepsis, and third is hypertensive disorder. WHO statistics suggest that 25% of the maternal deaths are due to PPH. And second important thing is PPH is the quickest of maternal killers. it can kill mother, a healthy woman, within 1 or 2 hours if not treated sometimes. So on one side, it is 25% of the maternal deaths are because of PPH. At the same time, it does not give much time to us for the management, and it kills mother in quickest. Incidence of PPH is reported as 2 to 4% after vaginal delivery and 6% after cesarean section. And we all know that with previous cesarean section, as number of previous cesarean section increases, possibility of getting placenta accreta, abnormal placentation, placenta previa all increases. And again, possibility of PPH increases. It is said every year about 14 million women around the world suffer from PPH. And these deaths have a major impact on the lives and health of families affected. Many times I have selected a topic for my oration at many places about 3 P's. 3 P's means PPH, PIH, and preterm labor. So PPH and preterm PIH are the major killer for mothers, as well as preterm is the #1 cause for the neonatal mortality. So if we can win over these 3 P, and if we can practice 4th P, that is preconceptional care, then we may save many women, many mothers from becoming critically ill or from becoming high risk or from their mortality also. Many times severe anemia, late referral, improper practice of blood transfusion, not diagnosis of placenta accreta during antenatal period. So many preventable causes are there, and these causes add fuel on PPH. So it is our duty to find out those, at least those preventable causes from which we can save the mother during the preconceptional period and during the antenatal period. And we should do counseling, and we should do whatever is required to save her life. So let us decide to work for no women should die from any preventable diseases. Of course, a title of today's webinar is very important and significant, that prevent the catastrophe, zero PPH world. If we all today decide in developed countries, PPH is not the #1 cause, and not many mothers are dying from PPH. If we all decide, we can also make India one of the developed countries, at least for maternal mortality. We should try to make India free from PPH before 2025. So it's good that today it is important and we are discussing PPH. But I hope so, because of lots of update. Now we have newer drugs, newer technology, so many things, newer and training of life-saving techniques, surgeries. I wish after 2025, we would be in a position that we may not require to discuss PPH more. Today, majority of the patients suffering from PPH, we are able to save them if we look at the admission utility rate of obstetric HDU and ICU. Then now for obstetric HDU, PPH and PIH are the #1 cause, and for ICU, they are not require ICU management. For ICU, respiratory problems and other cardiac problems are the major cause for the admission in ICU. So majority of the hemodynamic unstable patients are now managed at HDU level. And This is the importance of obstetric HDU and ICU. We can save them from becoming critically ill. We can save them from their admission in the intensive care units. So let us use all the backup. Let us know PPH thoroughly, and let us keep ourselves regularly updated, and let us perform drills regular to save mothers from PPH. Today we have very good topics, very eminent faculties, Dr. Poonam Verma ji, Dr. Jaydeep, Dr. Asad ji, and moderator Dr. Alka and Dr. Sazia. I think today we will have a very good deliberation, very good take-home message. I wish grand success to this webinar. Once again, I congratulate Jhansi Society, Moradabad Society, Dr. Archana, Dr. Pratik, Dr. Neharika, Dr. Rajendra, and all the office bearers and delegates for this webinar. I wish happy learning to all of you, and I wish safety to all of you. Thank you very much for patient hearing and giving me this opportunity. And at the end, I would like to take your 1 minute to inform all of you that FOGSI has so many programs in line. Tomorrow we have a program with FIGO and UNICEF on maternal nutrition, obesity and maternal nutrition. 17 is the World Prematurity Day. We have program on 20th and 21st on World Prematurity. 17th, on 17th, WHO is going to start campaign for the cervical cancer, and FOGSI has so many programs on 17th of November. And the most important two programs, first on 22nd of the November, that is Sunday. Previous Sunday, before the 25th November, across the world is celebrated for the elimination of prevention and elimination of violence against women. And FOGSI has a very, FOGSI wants to do lots of activity for this, because ultimately this is FOGSI's mission, FOGSI's vision. So we have program from 9:30 a.m. to 6:30 p.m. We have invited so many eminent faculties of different fields. So I request, at least for this purpose, we all should show our commitment unitedly and so with solidarity. And I hope all 258 societies will join for this program, and all 38,000 gynecologists will join this program. And our aim is to reach minimum 3 lakhs women. So please help us to take FOGSI's women mission to each and every corner of India. Please spread the message, please spread the program, please spread the competition, please spread the petition, and all the messages and scripts and everything prepared by FOGSI across India. And last 2 hours of the 22nd program is also we have dedicated for prevention and elimination of violence against doctors and healthcare providers. We cannot forget our members. We cannot forget violence against our doctors. So we have also 1 or 2 hours session for this specific purpose also. And 26th November is World Iron Deficiency Anemia Day. It is also related to PPH. Let us make all mothers free from anemia. So on 26 again, we have a very good program on anemia. Thank you very much for this extra time to me. And thank you very much once again for inviting me, for giving this honor. Thank you.
Thank you, sir. सर एक मन की बात, आपकी इतने सारे प्रोग्राम सुन के बस डॉक्टर प्रतीक, बस मैं एक 1 लाइन में एक अपने मन की बात बोल के मैं भी चलूं, खुद ही सर के लिए है वो, जो मुझे बहुत पसंद है ये लाइन, और जो मुझे बहुत लगता है कि इतना मेगा काम हो चुका है और या कोई मेगा पर्सनैलिटी होती है तो अपने आप से निकलती है वो बात, खुद ही को कर बुलंद इतना कि तकदीर से पहले खुदा बंदे से पूछे बता तेरी रजा क्या है। तो डॉक्टर अल्पेश सर, आपको तो ना ऊपर से उतर के पूछना पड़ेगा ना लोगों को, कर क्या रहे हो भाई आप? इतना अच्छा प्रोग्राम्स।
मैं तो अभी पूछता हूँ अर्चना जी, मैं क्या करूँ आगे? मैं तो आप सबको पूछता हूँ।
सर आप इतना आज तक मैंने देखा नहीं किसी भी प्रेसिडेंट को डायरेक्ट मैसेजेस भी इतना ज्यादा टाइम देना सबके लिए, छोटी से छोटी बात को, छोटे से छोटे बंदे को रिमेम्बर करना, ऑनर करना उसको, और लिखना, हर ग्रुप पे लिखना, दैट इज टू मच। kudos to you sir.
Very true, very true. Thank you.
हम लोग आपसे बहुत सीखेंगे सारे जूनियर।
From Jaydeep Malhotra. I am nothing against Malhotra for social media.
आप सर, आप सबके लिए अच्छे हैं।
Thank you.
Thank you, Dr. Alpesh sir, for your kind words of wisdom and your concern. We really appreciate your concern for women's health. That is something really great, and that is the mission of FOGSI. As we all know, hemorrhage is a leading direct cause of maternal death.
Dr. Pratik, he will say, let them say. Dr. Pratik,
that's fine. Let her continue. That's all right. Please go ahead.
No, sir, please.
I just wanted to thank sir for gracing the occasion and for giving us his words of wisdom. FOGSI has combated this pandemic situation in a unique way, and we've reached out probably to many more people, doctors as well as lay persons, in spite of all these difficulties. And it's hats off to Dr. Alpesh Gandhi sir. Thanks to him for his vision and for continuing in the mission even though we were facing so many difficulties over the past 6 months. Thank you so much for gracing the occasion.
Thank you.
Very rightly said, Dr. Pratik. So now, taking the program further, I just want to say that according to FIGO, more than 2/3 of reported deaths are hemorrhagic, and they are classified as PPH. Now, to prevent the catastrophe, we have 3 very important topics lined up for today's discussion. First is medical management of PPH by none other than our Honorary Secretary General, Dr. Jaydeep Tang, who's known to create history by holding successful virtual managing committee meetings and above all, FOGSI and ICOG elections. We welcome you, sir. Second topic is strategies for PPH prevention to be dealt by Dr. Asha Jain. She is the president of Raipur Society. Third topic in the series is surgical management of PPH by Dr. Poonam Verma Shivkumar. She is the professor and head OBGYN MGIMS Sevagram, Maharashtra. Now, to chair these important topics, we have very knowledgeable personalities. Dr. Rajendra Nagarkatti, he is the Chairperson Midlife Management Committee. Dr. Neharika Malhotra, Chairperson Young Talent Promotion Committee, FOGSI, and Dr. Saba, Asad, Vice President, Moradabad Obs Gyn Society. Now, please show the slide of Dr. Rajendra, please, Dr. Vipin. He is the Chairperson, FOGSI Midlife Committee and AMOGS, Executive Council Member, MOGS, Past President, Association of Fellow Gynecologists. He is the Joint Treasurer, AMC Mumbai Branch, Past President, Bhayandar Medical Association. He is Past President, IMA Mira Bhayandar Branch, Consultant Obstetrician and Gynecologist, Ashirwad Maternity and General Hospital, Wokhar Hospital, Mira Road, and Bhimsen Joshi Municipal General Hospital. Now, can we have the CV of Dr. Neharika? The young, bubbly, energetic talent of FOGSI is Dr. Neharika Malhotra. She is the Chairperson, Young Talent Promotion Committee, FOGSI 2020-22. She is the Joint Secretary 2018, Infertility Consultant, Rainbow Hospital, Agra, Executive Member of Society of Fetal Medicine 2020. She is an active member of IFUMB, ISAR, FOGSI, UPCON, SMT, ASP, Aspire, and NARCHI. And she has contributed so many books and chapters published. She has presented so many papers. There's a whole long list. I think the time is very short to read all, but hats off to your academic research and all. And we are really proud of you, Dr. Neharika. Now I hand over the mic to my co-moderator, Dr. Saba. Please proceed further with the...
Thank you, Dr. Alka. It is my proud privilege to welcome our Vice President, Moradabad Obs Gyn Society, Dr. Saba Asad. She is the consultant obstetrician and gynecologist from Moradabad, and she is from Aligarh, and she has done a senior residency from Delhi. And she's a very dynamic and a very active member of Moradabad Obs Gyn Society, and she's coordinated many projects and many activities she's regularly doing in Moradabad. Welcome, Dr. Saba. Now request Dr. Alka Sethi to please proceed further for the talks. We can move ahead for the first talk.
Now I invite Dr. Rajendra Nagarkatti to please start the first talk. Dr. Jaydeep Tank is the speaker. Please proceed further.
Thank you, Dr. Alka ma'am. At the outset, I wish to thank the conveners for this program, Dr. Archana Verma madam and Dr. Pratik Tambe, my good friend, both good friends actually, for having invited me here today to chair this session on this very vital topic. I also wish to thank Dr. Neharika Malhotra, Chairperson FOGSI Young Talent Promotion Committee, who is also the convener for the program. So it's wonderful to be here in the presence of such luminaries and dignitaries. And we all know that is an obstetric catastrophe. It's something which each one of us as obstetricians have faced at some time or the other. And we all know how dangerous, how horrendous it can be, as sir said, also that it's one of the fastest to cause death within just 1 or 2 hours also. So to understand this and to sort of prevent and manage this problem, we have a gamut of excellent speakers today. And it's my privilege, proud privilege, to introduce the first speaker for the day, none other than our dynamic and esteemed FOGSI Secretary General, who's also so very knowledgeable, Dr. Jaydeep Tang. He's currently the Secretary General of the FOGSI. He's immediate past President, Mumbai Obstetrics and Gynecological Society. He's the chair for the International Federation of Obstetrics and Gynecology, the FIGO Committee for Safe Abortions. He's Deputy Secretary of the Asia Oceania Federation of Obstetrics and Gynecology, the AOFOG. He's been awarded the FRCOG Honoris Causa in 2020 by the Royal College of Obstetricians and Gynecologists. Congratulations to you, sir, for that. Ex-chair Publication and Newsletter Committee, Asia Oceania Obstetrics Federation of Obstetrics and Gynecology, Reproductive Endocrinology and Infertility Committee, AOFOG. He's the chair of the he was the chair of the MTP Committee of FOGSI in 2004 to 2009, Vice President of the FEQH, which is the Forum for Enhancement of Quality in Healthcare. He's a consultant at Ashwini Maternity and Surgical Hospital, Ghatkopar, Mumbai. And he's also a program director and member of the board for Profert IVF Center, where I am also privileged to be a member of the same Profert IVF, and it's our privilege to learn from him. So he's of course got many more awards to his credit. He's instrumental in drafting the proposal for FIGO, which has resulted in a grant of $13 million for a 10-country project, 8 in Africa and 2 in South America, and is the technical head for the project. So that is something which is very creditable. So moving on, I would love to invite him to present his talk on medical management of PPH. Over to you, Dr. Jaydeep Tank.
Thank you very much, Dr. Nagarkatti, for that very kind and very generous introduction. I have known Dr. Raju since I was almost a child, I think, because he was working with my father also for some time, and it's always such a pleasure to meet him, hear him, and listen to him. I must begin by thanking and acknowledging the conveners of this program, Dr. Archana Verma and Dr. Pratik Tambe, the chairpersons, Dr. Raju Nagarkatti, Neharika, and Dr. Saba, Asad, my co-speakers, Dr. Asha, Jain, Dr. Poonam, Varma. We know they have done a lot of work for PPH. And of course, the president and secretaries of Jhansi and Moradabad Society, along with the entire executive committee, the president from Jhansi, Dr. Sanjay Sharma, and Dr. Secretary, Dr. Alka Sethi, and from Moradabad, Dr. Nidhi Thakur and Dr. Shazia Mones. Thank you very much for giving me this opportunity. You know, a few days back, I was watching that movie on television. It was being shown again. You all must have seen it, Jab We Met, with Kareena Kapoor and Shahid Kapoor. And in that, there is this dialogue where Kareena Kapoor says, मैं अपने आप को बहुत पसंद करती हूँ, मैं अपने आप की favorite हूँ. So I really like that movie because I can see a lot of my favorite people just now in this webinar. There's Archana Verma. She's so enthusiastic. She's so capable of putting things together in a very, very nice way, taking everybody along. There is Neharika, there's Raju and everybody. And of course, everybody. And I must especially mention Dr. Alka Sethi. I actually called her up one day to tell her that I go to so many webinars and I always see madam over there, and she's always patiently listening to all the lectures and interacting, and I must really appreciate that because it's not very easy to sit through so many webinars. So thank you very much for inviting me. Let me start this presentation with this. This is a screenshot of a Medline search. Whenever you do a Medline search for any topic, you always get a small graph on the side, which I have blown up at the bottom of the slide. We don't pay enough attention to this graph, but it's actually a very important graph. This graph tells you about the number of articles that have been published on the topic that you are searching for every year. So when you do a search for PPH, for example, you can look at the number of articles that have been published from 1854 to 2020. This by itself shows you that PPH has been a topic of interest in literature since centuries. But look at the graph and understand that if you have a graph which starts tall and then keeps on going down, it means that the number of articles that are being published on that topic are reducing every year, and therefore that topic is not of much interest in current literature, or maybe all the issues which surround that topic have been solved. But if you get a graph like this, which starts small and then keeps on increasing, it quite clearly means that a lot of articles are being published on that topic in current literature, and therefore that topic is extremely relevant and is of great interest to current literature. It's rather, in a way, sad that even at this point in time, we still need more and more articles on PPH. You would have thought that being one of the leading causes of maternal mortality, all the issues which surround PPH would have already got solved, and we would now be on the cusp of eradicating PPH one way or another from our maternal health scenario. This, unfortunately, is not the case. Besides doing the Medline search, in the course of preparing this presentation, these are the guidelines that I have referred to. There is the WHO guideline, there is the RCOG guideline, and there is, of course, the Government of India guideline. But there is also this excellent resource, which not many people use, which is the RANSCOG website, which is the Royal Australian New Zealand College of ONG. That website gives you these guidelines for free, and I can tell you as a matter of fact that they are excellent guidelines. They are very pragmatic, and they take into consideration the fact that not everybody has the same kind of resources. Having said that, besides giving you a presentation from the literature and from the guidelines, I'm also going to add what I have learned from over 25 years of delivering babies in a nursing home setup. Because remember, India is a land of contrast. We have this very fancy tertiary care hospitals with all the possible facilities. And then you have people who are practicing in very resource poor settings, where even if you are the most excellent surgeon, sometimes it's so difficult to get blood. You may be able to do everything to save the patient, but if you don't have blood, what in the world are you going to do? And I think these considerations are sometimes not covered in international guidelines. And therefore, I have always felt that when we make guidelines, we have to make as is, guidelines which fit resources or resource settings right from the most high tech to the most resource poor. Because it's important to remember that not every guideline fits every situation. I am now going to talk about the medical management of PPH. And the first step towards the medical management is to diagnose the PPH. It is quite a well-known axiom that we tend to underestimate blood loss. There has been more than enough literature to show that particularly in a situation of PPH, physicians, clinicians, auxiliary staff, midwives, everybody across the board tends to underestimate blood loss. Therefore, if you think this patient has had excess bleeding, the first thing I would like to tell you is always double what you have estimated. If you give that patient 1 or 2 uterotonics more, probably you're going to do less harm than delaying the diagnosis and landing up with a patient who becomes serious and becomes bad. Remember, underestimation of blood loss is probably the number one reason why there is a delay in diagnosis, and you need to be very, very careful about this. This is a chart which we have put up in our labor room, and this is quite helpful for us. You see, what happens typically in PPH is that the massive gush of blood occurs very rarely. Most of the times, patients who suffer from PPH and have dire consequences are patients where there is a slow trickle rather than a massive kind of a bleeding. And if you have this chart, which is hung up on your labor room, it is hung up on my labor room, simply by looking at the number of pads or tampons or gauzes, we can estimate the blood loss a little more accurately. Remember, when you are suturing the episiotomy or anything, don't throw away the gauze pieces or the pads that you are using into the dustbin. Keep them in another kidney tray so that you have some idea about the amount of blood loss that is happening. So if you have a regular pad that's around 120 cc of blood, a tampon will have around 50 cc, a gauze 30 cc, and a mop, a small mop around 250 cc, and a large mop will have 450 cc. So the first and most important thing I can tell you is never underestimate the blood loss. And if you think that patient is bleeding, think of what that blood loss may be and double it, because that really will usually be the true blood loss. For medical management of PPH, I cannot overemphasize how important the cannula that you put into the patient's vein is important. Please look at that chart where you look at the time to infuse 1000 ml of normal saline and compare that to the gauge of the IV cannula. If you use a 22 gauge blue or a 20 gauge pink cannula, and I can tell you that these are by far the most common cannulae used for various interventions in various nursing homes, you are going to take significantly more time to infuse fluids. That is because the flow through an IV cannula is inversely proportional to the fourth power of the radius, something called the Poussier's law. So small changes in cannula diameter make for large changes in flow. So if you have a patient who's got a 20 gauge cannula, the time to infuse 1000 ml of saline, and this is saline, this is a crystalloid. We are not even talking about blood, which is a fairly strong colloid. You're talking about crystalline saline. If you have a pink cannula, you will take 15 minutes to infuse 1000 ml. But if you have a 16 gauge cannula or a 14 gauge cannula, that time is more than halved. So in patients where you are either expecting that there will be PPH, or in patients where you are suspecting that there is already PPH, one of the first things that you must do is put in a large bore IV cannula. This slide actually I saw for the first time in one of Professor Arul Kumaran's lecture. And I thought that this slide was so important that we discussed it, but Dr. Parikshit, my brother and me, we discussed it. And we used to put 18 gauge cannulae for all our obstetric interventions. We have now switched to 16 gauge cannulae because really the cannulae number that you choose can sometimes mean the difference between life or death. Diagnosis has already been talked about. There's stone, tissue, trauma, and thrombin. The important thing I'd like to tell you here is that once you're suspecting PPH, move rapidly towards a diagnosis. Don't wait to see whether she's losing blood or not. First, make your diagnosis. Is it atonic? Is it traumatic? Because the treatment of each is dramatically different. If it is a traumatic PPH, you need to repair the trauma. If you don't repair the trauma, she's not going to stop bleeding. It's as simple as that. And therefore, move rapidly towards a diagnosis. And once you've established a diagnosis, then start treating that patient rapidly. One of the first things that you should do is call for help. It doesn't matter how capable you are individually. Every hand is important when you're dealing with PPH. I think Alpesh Bhai just made the point that it kills very fast. And if you are faced with a patient who really has PPH, then you're going to find that you will probably need as many hands as you possibly can avail. So as Atul Gawande said, man is fallible, but maybe men are less so. It's always useful to have a fresh perspective. You know, it's like you have this patient in labor, she's not delivering, you've been doing her PVs every 2 or 3 hours, and then you really don't know what to do. At that time, sometimes somebody else comes, does a PV and says, you know, why are you waiting on her? You've already waited long enough. Just go ahead and do the cesarean. A fresh pair of eyes, a fresh perspective is very important. And therefore, in the medical management of PPH, the first thing that you should do is, in fact, call for help and try and have as many people on the floor with you as possible. I've already said this, intravenous access can sometimes mean the difference between life and death. And it's important to put this access earlier. If you wait too long, by that time, if the BP has already gone low, you will not be able to put such a big vein flone. That 14 number vein flone is really quite thick, and so is that gray colored one. If you wait long enough for that BP to come down, you will not be able to gain access because not only are those cannulae thick, but they are also long. So you need vessels which have a good pliability and which are not collapsed before you put this. Another trick that I have found is useful is that once I put the cannula a little, I start the IV. That sort of expands the blood vessel and allows the cannula to go easily. So if you're punctured once or twice in a patient who's a little bit shocky, a little BP is a little low, that could be a useful trick to gain IV access. I'm emphasizing a lot on IV access because I have seen this happen, and I have been called to help people in situations with, and they have put in the blue vein flone or the pink vein flone, and then it's really so difficult for that patient to receive the blood, etc. Once you have gained this access, you have to measure the pulse, the respiratory rate, the blood pressure recording every 15 minutes. Try and immediately start the patient on crystalloids. Although these are the RCOG guidelines, colloids should ideally be reserved for patients who have major PPH. In patients who have moderate or mild PPH, try to use crystalloids more than colloids to prevent overloading the patient. What are the drugs you can use for medical management? Intramuscular oxytocin, and these are the government guidelines. Sublingual misoprostol. The government guidelines again say isotonic crystalloids are recommended. Tranexamic acid is recommended, and you should ideally have a blood storage unit either in your hospital or somewhere near you where you have regular contact. So medical management consists of bimanual uterine compression, that's rubbing the fundus to stimulate contractions. And when you rub the fundus, it's very important to make sure that it's continuously done. If that patient has atonic PPH and you don't continuously rub the fundus, that patient's uterus will relax in between, the uterus will collect with clots, and then when you press, you will have this big gush of blood coming out. So don't let up on rubbing the fundus. Make sure the bladder is empty. Put in a Foley catheter, leave it in place. Start syntocinon. They have written 5 units over here, but we normally start with 20 units or even 40 units directly. depending on how much the blood loss seems to be. You could even use ergometrin, and you can consider using carboprost, even direct intramyometrial injection of carboprost or misoprostol 1000 micrograms rectally. Our protocol in our nursing home, and remember, I practice in a nursing home, I don't practice in a big tertiary hospital. So our protocol in a nursing home is to immediately start 20 units of oxytocin, put in 600 micrograms of misoprostol, 600 because that's the tablet which is available. So we put in 600 micrograms of misoprostol. Remember to put it in rectally and not vaginally, because if you put it in vaginally, it will come out with all the bleeding that is taking place. And if we think that in around 5 or 10 minutes, the bleeding has not stopped, we immediately give injection carboprost. There is a recommendation now to also use tranexamic acid. Remember, this trial was done for treatment of PPH and not for prevention. The trial for prevention is ongoing and the results have not come out yet. In patients where you think there is PPH, have a low threshold for blood transfusion. Remember, we never think of blood transfusion in terms. We always think that we'll decide that we are going to give blood and the blood arrives. But in our country, particularly in nursing home settings where there are no blood banks, remember the time it will take for the blood to arrive. I cannot emphasize how important it is. The minute you think that she will need blood, we normally do this, that we send one relative to the blood bank. We tell them, you wait over there. If she needs blood, then you wait there, we'll phone you up, you get the blood and come immediately. So in patients of placenta previa, twins, polyhydramnios, all the well-known risk factors, we have one relative waiting in the blood bank in case we need the blood. We don't wait till, like we think that now the blood will be needed, then you send the relative and so on and so forth. You cross-match from the beginning, keep the relative waiting over there. Let the patient also share a little bit of your tension. I see no harm in that. Let the relative wait there, and if the blood is needed, remember that's cutting down half the time for the blood to arrive. So remember this, account for half an hour for the blood to arrive before you're going to be able to start the transfusion. The blood will come. If it's major PPH, of course, you don't wait for the blood to warm up. Otherwise, you wait for the blood to warm up and then you give the blood. So from time of decision of transfusion to time of the transfusion, it's going to take another half an hour. Keep that in mind before you decide to delay blood transfusion a little bit. So these are all the ways in which the blood products can be used. Remember that if you have given a massive amount of transfusion, always use FFP. Cryoprecipitate can be used for fibrinogen replacement, and you should keep on monitoring the platelet count and SOS give platelets. This is essentially telling you how much, up to 1 liter of FFP and 10 units of cryoprecipitate may be given empirically in the forms of relentless bleeding while awaiting the results. So what are your goals of management? When will you say that now you're okay and you don't need surgical management? If the hemoglobin remains above 8, if the platelet count remains above 75,000, if your prothrombin is less than 1.5 and APTT is less than 1.5 and fibrinogens more than 1, and of course, the patient has stopped bleeding. In all these situations, you will now say that, all right, now she's doing well. I don't need to worry about surgical management. These are all the things about which there is insufficient evidence, and this is from the WHO recommendations. There's insufficient evidence to recommend the use of recombinant factor 7A or intraumbilical vein injection of oxytocin, or to recommend the measurement of blood loss over clinical estimation of blood loss. This means that, whichever way you measure, your clinical judgment for estimating blood loss remains most important. And the last thing, but pretty much the most important and probably life-saving thing for medical management is don't hesitate to move to surgical management. Remember, if you're not working in a tertiary care hospital, embolizing the uterine artery, embolizing this, that, and the other, selectively ligating vessels and all may be all very good in tertiary care centers. But when you don't have access for minute-to-minute monitoring and when your manpower is not the best, don't hesitate to do an obstetric hysterectomy. Let me give you an example of what I mean. At our hospital, which is a nursing home of around 20-25 beds, we do around 50 to 60 deliveries a month. We normally do maybe one, at the most two obstetric hysterectomies in 3 or 4 years. The incidence of OB hysterectomy should be that low. When I say don't hesitate to do a OB hysterectomy, it should not be taken the other way to mean that you can go ahead and do OB hysterectomies willy-nilly. But in case it is required, in fact, the last 2 OB hysterectomies we did them one in every month. So we did one in May and we did one in June. And after that, now there's been a long spell. Let me not say it, otherwise I'll have to do OB hysterectomy tomorrow only. But the point I'm trying to make here is that if surgical intervention is required, don't hesitate to do a OB hysterectomy. In this instance, it really could be a life-saving thing. For abnormally adherent placentae, although they talk about methotrexate, leaving the placenta in, etc., be very, very careful, because when these patients bleed, they bleed catastrophically. You will not get more than 15 or 20 minutes to. At times in this kind of a situation, particularly if you're working in a nursing home, a better option rather than being conservative is to simply go ahead and do an OB hysterectomy. A rare situation, but one that occurs nevertheless, is secondary PPH. These patients typically come back to you because either of retained products of conception or postpartum endometritis. The treatment for this is normally medical, hardly ever surgical, because if she's got an infection, to operate on that patient is going to be very, very difficult. The tissue is going to be so edematous and so friable that you'll find it difficult to actually apply the clamps and make sure that the stitches remain around the clamps. Hesitate a lot before you decide to operate on a patient of secondary PPH. And lastly, let me end with this sentence, which talks about the need to be realistic when we are counseling our patients. What do I mean by realistic? It is that we get so attached to our pregnant patients. We have been looking after them for 9 months all the time. And we always try to tell them, Baba, don't worry, you'll deliver nicely. I'm there, no. I will hold your hand. I'll give a nice little episiotomy and you will deliver a healthy child. I've delivered like thousands of babies and you'll be fine. Inject a dose of realism into the fact that not all deliveries are uneventful. To wit, the statement by Marsden Wagner, which says, nowhere is maternal mortality or perinatal mortality zero. Throughout history, women have accepted this harsh reality until recently, when doctors began to promise perfection. Now, when something goes wrong, women and families feel deceived and seek answers. And that really is sort of the basis upon which all the unrest which occurs for patients takes place. Let me end by saying, therefore, this quotation from Robert Stuberg: the trouble with so many of us is that we underestimate the power of simplicity. We tend to mistake movement for achievement. And I think this is so true of PPH. It's actually very simple to manage PPH. Identify it, treat it medically, and if within a certain finite period of time it doesn't work, go ahead and do surgical management. And that's all there is to it. Of course, there are a whole lot of nuances in it, but keep it simple, move fast, and get help. Thank you very much.
Thank you, Dr. Jaydeep, for this excellent, detailed, practical talk on the management of PPH with so many important take-home messages. I think one of the most important being to use a large bore, a large gauge IV cannula, which is something very, very important, where you need to give infusions very fast. Also to reserve blood wherever you're suspecting a problem, and also to go in for surgical interventions wherever it is necessary. Don't hesitate too long, because that delay might be again the this between life and death. So thank you once again for this wonderful talk. And are we inviting questions now, or I think at the end of the
Do it at the end.
At the end of the talk, Dr. Jaydeep Tank, आपके लिए अगर मैंने कुछ बोला नहीं तो फिर थोड़ा मजा कम रहेगा. Dr. Jaydeep Tank is such a person, अभी सब लोगों ने बहुत कुछ बोल दिया है, वो सब ठीक है। और मतलब ही इज सच अ ग्रेट एकेडमिशियन और इतना मतलब ही इज सच अ नाइस एंड ग्रेट लीडर ऑल्सो। सबको इतना सपोर्ट करते हैं। देखो अभी डॉक्टर अलका सेठी के लिए भी कितना अच्छा बोला। और मैनेजमेंट का तो डॉक्टर सर बहुत, इट वाज रियली आई ओपनर, वेरी गुड, वेरी वेल डॉक्यूमेंटेड एज यूजुअल, एक्सपेक्टेड फ्रॉम यू। एंड वन थिंग एक बोलूंगी, झूठी शान के परिंदे ही ज्यादा फड़फड़ाते हैं, बाज की उड़ान में कभी आवाज नहीं होती। That truly your personality.
Thank you, Dr. Archana. Thank you.
And madam,
Next
I can
time
say
you
that
are-
in spite of being so highly academic and so much accomplished, I may say, is so down to earth and
Down to earth and friendly also.
That
कभी
is,
किसी
yes.
भी टाइम फोन करो तो एकदम within minute आंसर, कुछ भी किसी भी टाइम। he was so busy in election, एक कभी लिखो within second आंसर। nobody every gynecologist से बहुत बिजी है, हमारे सिर में दर्द हो रहा है, हमारे यहाँ ये हो रहा है, हो रहा है। एंड सर बहुत respectfully भी जवाब देते हैं always. It is not like this, since years we are seeing him like that. Thank you, sir. Thank you for accepting our invitation. And this PPH sub forum I want to do so much, and that patient के mind में भी counseling से भी भरना है, and even police and DM and सबको कि अगर कहीं कोई PPH हो रहा है तो सारे doctors भी united रहें और सारा उनको भी समझ में आना चाहिए कि what is PPH dreadful है, उसको manage करने में भी, और उस against उसके इतना क्लियर कट उनको होना चाहिए कि हेमरेज अगर हुआ है तो कोई डॉक्टर की इसमें नेग्लिजेंस नहीं है, और जितना, और नेग्लिजेंस हमारी तरफ से नहीं होनी चाहिए। वी शुड बी वेरी वेल अपडेटेड एंड स्किल्ड डेफिनेटली, एंड बहुत अलर्ट होना है, अलर्ट अलर्ट अलर्ट।
Thank you, Dr. Archana, for the message, and thank you very much, Dr. Jaydeep, for the brainstorming wonderful session, and special thanks to Dr. Rajendra for chairing the session. With permission of Dr. Archana, can we start the second talk? I invite Dr. Neharika Malhotra to please chair the second session. Dr. Neharika, please.
Yes, ma'am, I'm here. Thank you, Dr. Tang sir, for this wonderful talk. And I think we all have revised the full management, and we would now take home a great message from you. And it was very practical, and I hope all our viewers have understood it well. And we have few questions, but I think, sir, we'll take it after this next talk. So
no problem, anytime.
Yes, sir.
अजय, डॉक्टर प्रतीक आपने बहुत अच्छा कन्वीन किया है लोगों को, मैक्सिमम अटेंडेंस आई कुड सी। अभी थोड़ी देर पहले तो इट वाज टू मच। थैंक यू, वेरी हिट प्रोग्राम। चलो निहारिका प्लीज।
Yes, so, ma'am, can we call our next speaker now?
Now the stage is yours.
Thank you, ma'am. And it gives me great pleasure today to invite Dr. Asha Jain, and we all know her very well. She is director of SMSA Raipur, also been the medical director of CPRS Raipur, and she has worked very hard with the Raipur Obs Gyn Society and also with the Rotary Club in North. Welcome, madam, and we are looking forward to hear your views.
Thank you, Neharika, for that kind introduction. And I will be starting strategic planning. So, my topic today is strategies to prevent PPH. And this is two images from the past. One is Mumtaz, the Taj Mahal, very familiar to you, Neharika. Mumtaz Mahal died in her 14th pregnancy of PPH. And recently we have Smita Patil, 30 years back, again, who died of PPH. So PPH is an ongoing problem, and as Dr. Pratik sir has shown, that the number of publications are rising and rising. And what is the strategy that we have to think about? It's like balancing this ball on this or balancing on the razor edge. You don't know which patient is going to go bad. You don't know when she's going to go bad. But yes, we have to postpartum hemorrhage. We have
So
to
something
predict.
echo. Excuse me. Dekho, Dr. Vipin, some echo coming.
Okay. Yes, ma'am. Please continue. Please continue.
Okay, thank you. So this is what Archana madam suggested. Postpartum hemorrhage, predict and prevent the hemorrhage. So we proceed from here. We also prevent and predict heartburn. This heartburn is for the doctor and also for the patient and the family. If the patient has lost the family, and it gives the doctor a lot of heartburn. So what is going to happen? This is what Dr. Tank has already covered, that we need formal protocols by health facilities for prevention and treatment of PPH. The use of formal protocols for referral of women to a higher level of care recommended for health facilities. As Sir just said, that we are so attached to our patients that sometimes we don't want to refer them. But if you feel that this patient is risky as per your protocol, then it is better to refer to a higher level of care. The use of simulations of PPH treatment. So protocols and then drills, as Alpesh Gandhi sir said, PPH drills is recommended for pre-service and service training programs. And then there is also the monitoring the use of utrotronics after birth for the prevention of PPH is recommended as a process indicator for programmatic evaluation. That means utrotronics have to be used irrespective of what. And if this doesn't happen, the second part is, you have to be at good terms with your colleagues, your doctors who will come to help you. You need to have indemnity insurance. FOGSI has a good scheme. You need to be friendly with your local police. You need a good lawyer, and you need insurance cover for yourself and for the hospital. So this is the critical support that if you're practicing obstetrics and gynecology, you need all the time. The acronym I have made is DILLI, DILLI, Doctors Indemnity, Local Police, Lawyer, and Insurance Cover. Protocols and practices in the hospital have to be perfected. Why do we need protocols? So here you can see that the patient is on the floor and the legs are in the attendant's hand. And what they're saying is, and that is why we lift on 3. So we need a protocol. Everybody needs to know what they have to do in that protocol. And it has to be drilled into them so that accidents like this don't happen. Prediction of PPH, the 4 T's. Sir has taken them in brief: tone, trauma, tissue, and thrombin. Thrombin or the clotting disorders. Now we will see their prediction one by one. The risk factors for PPH may present antenatally or intrapartum. And the care that is given to the patient has to be modified as and when the risk factors appear. Clinicians must be aware of the risk of PPH and should take this into account when counseling a woman about planned delivery. And women with known risk factors should only be delivered in a hospital that has a blood bank on site. This is a guideline. But as Tank sir has just said, that we can always have somebody in the blood bank to half the time and have a very low threshold to analyze the blood amount that is lost and to double it. Minimizing risk, treating antenatal anemia. This is a very important point that Alpesh Gandhi sir just said, but we need to remember that if a patient is already anemic, the amount of blood loss, half liter, 1 liter is not important. She may become she may become anemic with a very little blood loss. So antenatal anemia has to be corrected. And if a woman is being given iron and is not responding, we need to find out why she's not responding. And that anemia has to be corrected antenatally. We need to minimize the risk by reducing blood loss at delivery. So a recent study, 2016, has shown that uterine massage is of no benefit in prophylaxis of PPH. So not prophylaxis, but as Sir said, that you need to give it in case the uterus has relaxed, but it cannot be a very prolonged affair. Prophylactic uterotonic should be routinely offered in the management of third stage of labor in all women, as they reduce the risk of PPH. For women without risk factors for PPH delivering vaginally, oxytocin is the agent of choice for prophylaxis in third stage of labor. A higher dose is not found to be beneficial. Continuing with minimizing the risk, if a woman is delivering by cesarean section, 5 units of oxytocin by slow IV injection should be used to encourage contraction of the uterus and to decrease blood loss. Ergometrin with oxytocin may be used in the absence of hypertension in women at increased risk of hemorrhage, as it reduces the risk of minor PPH. For women at increased risk of hemorrhage, it is possible that you need a combination of preventive measures, not just oxytocin. Clinicians should consider the use of IV tranexamic acid, 0.5 to 1 gram, in addition to oxytocin at cesarean section, to reduce blood loss in a woman with an increased risk of PPH. So now we come to the 4 T's that we have to prepare for them, be aware of them. Decreased tone is responsible for a lot of PPH. So what we have, over-distension of uterus. The first T is tone, over-distension of uterus. So if the patient has polyhydramnios, multiple gestation or macrosomia, if she has amniotic infection, fever, prolonged rupture of membranes, if there is anatomical distortion, rapid labor, prolonged labor, if she has fibroids, if she has placenta previa, if there are uterine anomalies, in that case, we have to think. If she is on muscle relaxants, magnesium, terbutaline, halogenated anesthetics, glyceryl trinitrate, then these are risk factors. And bladder distension. A simple thing like a distended bladder may also interfere with contraction of the uterus. So this has to be thought of. And out of this, as you can see, anesthesia, anesthetist already knows when he's giving general anesthesia. Then we know rapid labor, prolonged labor. We know the presence of fibroids, placenta previa, or placenta accreta spectrum, uterine anomalies, long before the patient comes in labor, unless she's an emergency admission. So many of these things can be prepared for. Then the second thing is the tissue. If there is a retained cotyledon, succensurate lobe, if there are retained blood clots, if there is placenta previa, placenta accreta spectrum, placenta accreta and previa can be known beforehand. It is very handy to have an ultrasound machine in the labor room or near the labor room. So you can just put a probe and confirm if anything is left behind, if clinically you're not able to do it well. The third is trauma. Now trauma, injury to the cervix, injury to the perineum, vagina, extensions, lacerations at cesarean section due to malposition or deep engagement, if there is uterine rupture due to previous uterine surgery, or inversion of the uterus because of high parity with excessive cord traction. So some of these factors we are able to know beforehand. Pre-existing states like hemophilia A, there is a history of hereditary coagulopathy or liver disease, idiopathic thrombocytopenic purpura, patient presenting with bruising, wall Willebrand's disease, History of previous PPH is another thing that we can know before. What is acquired in pregnancy? Gestational thrombocytopenic purpura, which presents as bruising, and preeclampsia with thrombocytopenia or the HELP syndrome, which can be diagnosed by elevated blood pressure. So as it was said that, being comfortable with somebody else taking the blood pressure is not so good. You need to see that the blood pressure is taken well. Then there is a patient who presents with disseminated intravascular coagulation, which could be a complication of PIH, in utero fetal demise, severe infection, abruption, or embolus, or there could be a therapeutic anticoagulation. And this is presenting as a coagulopathy, fetal demise, fever, antepartum hemorrhage, collapse, or a history of thromboembolic disease. So now, when you see all these 4 factors, then you're going to predict that this patient is likely to have PPH. Now, how are you going to prevent this PPH? What are you going to do? This is most important. Dr. Jaydeep just said that you keep examining the patient every 2 hours. But if you maintain a good partograph in your labor room, in that case, you will find that whenever there is arrest of active stage of labor in the second stage, or the second stage has been prolonged, or the third stage is being prolonged, a partograph will help you to identify. It also has the signs of maternal distress. So if the mother's pulse is going, as Dr. Archana Verma said, that there is the shock index. So all this can be seen on the partograph if you have trained your staff to actually keep that partograph. If you see this chart, the risk factors are many, but the risk factor and the relative risk, what is the percentage of patients presenting? A retained placenta has a 7.83% contribution. Prolonged third stage, 7.6. So it is basically the placental things. Placenta accreta is only 3.3, but an episiotomy has 4.7. So a relative risk with a simple episiotomy that we don't even count as a trauma. So we have to be really, really aware and see that not everything is contributing the same, but everything is contributing. And if your patient goes bad, you've had it. So these risk factors have to be looked for, and they have to be managed, predicted, and once diagnosed, they have to be managed. So there are 12 recommendations for prevention of PPH by WHO. The use of uterotonics in the third stage of labor for all women. Number 2, oxytocin is the drug of choice. Then where oxytocin is not available, you can use ergometrin, methyl ergometrin with syntocinon as a fixed drug combination, or oral misoprostol. In settings where skilled birth attendants are not present and oxytocin is unavailable, the administration of misoprostol by community healthcare workers and lay health workers is recommended. In settings where skilled birth attendants are available, controlled cord traction is allowed, but where they are not available, controlled cord traction is not allowed. Late cord clamping is to be done for everyone, except for the baby who is already asphyxiated and needs to go for care immediately. Sustained uterine massage is not recommended as an intervention in a woman who has received prophylactic oxytocin. Postpartum abdominal uterine tonus assessment for early identification of uterine atony is recommended for everyone. Oxytocin is recommended for uterotonic drug for prevention in cesarean section, and controlled cord traction is recommended in cesarean section. Now, what happens if you ignore? You ignore this at your peril. This is what happens. There is public-private humiliation. The patient has PPH and you have PPH and your life is a mess. Then you need Delhi and you need all the help that you have. So what do? There has to be a good communication between your staff and you, the people who are managing, and you and the patient. Sometimes the reality is complex. So one side is 4 and the other side is 3, and both are right, but that is not the communication you want to give. So you have to understand that when you're communicating, you are on the same page. This is an office memo. The job isn't finished until the paperwork is done. So you need to do the paperwork. So the third PPH is paperwork, and do it like your homework. Because unless the paperwork is correctly done, all your risk management will stand you to no help in the case of problem. And then come documentation and debriefing. What documentation do you have to do? It is important to record the staff in attendance and the time they have come in, the sequence of events, the administration of different pharmacological agents, their timing and sequence, the time of surgical intervention, the condition of the mother throughout the steps that were taken, the timing of the fluid and blood products. So your documentation has to have these 6 things. If it is not there, something is missing. And then comes the debriefing. This debriefing is where everyone is on the same page. When your patient, the definition of debriefing is a meeting that takes place in order to get information about a particular piece of work that has been finished. For example, about what was done successfully and what was not. So your patient has recovered. So you need to find out what went well. You need to share it with your staff, and you also need to share it with the family. And the second aspect of that is, if that is a primary and you have had to do a procedure, or you have diagnosed a placenta previa in a primary, in a precious patient, in that case, in her pregnancy itself, you have to talk to her that what can be the problems in future. And all this is called as debriefing for critical incidents. And this is part of the protocol. After everything is done, there is an audit. And in this audit, you need 100% response in these 6 things. Otherwise, you are failed in your audit. So the proportion of women who are screened for antenatal anemia has to be 100%. Those who are offered uterotonics for 3rd stage, 100%. The proportion of women undergoing an assessment of risk factors for PPH when they present in labor, 100%. Appropriate documentation of management, especially with the timing of events for women who have had PPH, 100%. Notification to the risk management team of women with PPH involving a blood loss greater than 1500 ml. You just have to inform your risk management team in case the blood loss has been more, and that is again 100%. And the skill training for the team that is going to manage such problems has to be 100%. So this is the audit that you have to do periodically so that mistakes are prevented. You can predict and prevent. After all this is done, there is certain amount of research that is still pending. And what is that research? That research is we need RCTs to identify best drug combinations, the route and dose of uterotonics for treatment of primary PPH. The viscoelastometric point of care test using TEG and ROTEM in the management of PPH requires evaluation. Studies are required to determine the optimal ratio of packed red cells to FFP in the management of obstetric hemorrhage. Studies are required to determine the role of fibrinogen concentrate in the management of PPH. The role of prothrombin complex concentrate in the management of PPH also requires evaluation. And last but not least, RCTs are required to investigate the role of uterotonic agents, misoprostol and ergometrin, in the management of secondary PPH. So in PPH, these 6 areas are the ones where we need more research. And with this, I hope may all of your stories have a happy ending like this. We started with Smita and we end here. Thank you for a patient listening. Namaskar. Thank you.
Thank you so much, madam. It was such a wonderful presentation. And thank you. We are really grateful to have you here today. Thank you, ma'am.
Thank you. Thank you. I hope I didn't
1
overshoot
minute
my
हाँ
time.
ओके डॉक्टर प्रतीक अभी कुछ अपना कमेंट पहले दे दीजिए फिर देन आई विल आल्सो डॉक्टर
It
प्रतीक
was a
प्लीज
very lucid, very precise, and very factual talk. I think it was something which added to everything which Dr. Jaydeep Tang could not cover, and it complemented his talk. So often it happens then when you have several speakers, they tend to overlap each other, and the audience also gets bored. Chairpersons also say, "ये हो चुका है, अभी वापस क्यों बोल रहे हैं?" So I take hats off to her for being wonderful in understanding what to say, how to say it, and being very precise in saying it. Thank you so much, Dr. Asha Jain.
दिस इज द
Thank you, sir.
ओनली थिंग ना
Thank you.
वी टेल आवर फैकल्टी पीछे से ये बोलना है ये होना है गुड डॉक्टर निहारिका कैन आल्सो स्पीक सो मच बट अभी रुको अच्छा ओनली थिंग आई वांट टू से कांग्रेचुलेट आशा फॉर वेरी नाइस टॉक स्टार्टेड विद स्मिता पाटिल's photo and of course the and Aishwarya Rai's photo. So I wish each and every woman not have the faith of Smita Patil and let be glowing like Aishwarya Rai. And we are averting our main aim is in averting maternal death. That is based on all everything. Now for prepare, I've got a one very amazing video with me made by one of the Indian boy only in a 5th standard. Please see it. It is a PPH cup. It is for the just management in the case of PPH and that estimation of the blood loss. It is, I think it is going to change the scenario. Please, Vipin ji, please play the.
More mothers die during childbirth than soldiers die in war.
Measuring the exact blood loss is very vital in the treatment of PPH during the golden hour. But the irony is that till date there is no single method that has proved to be the best and accurate. My remedial novel invention, the PPH cup, does exact and real-time measurement of the blood loss after delivery by a simple device known as the PPH cup.
It is being used by maternity hospitals, medical colleges successfully. I hold the intellectual property rights of my product.
I pray to incorporate the PPH cup in maternal health care of Government of India, WHO and UNICEF. Henceforth, if you come across a death of mother due to PPH, you should always think of Archit PPH cup.
Periodic suction to avoid blockage of the system. Thank you.
I was really impressed to see this cup, and somehow because it's like mimic my name also Archie, so I really like it. And Dr. Pratik, me and you are going to make the PPH awareness very popular. So thank you very much. I hope
जी मैम, you lead, we will follow. आप जहाँ ले जाए.
So I think this is a very good thing, and it was recommended by Dr. Poonam, who is a really a brand and firebrand obstetrician dealing with so many obstetric emergencies, and no one can, I think, be better than Dr. Poonam to promote this AV cup, not AV cup, RG cup, and let hear to her. And please, Alka and Shazia, carry on, and let's hear from Dr. Poonam.
Thank you, Archana ma'am. Now invite our third chairperson, Dr. Saba Asad, for the third talk by Dr. Poonam Verma. Dr. Saba, you need to unmute yourself.
Yes, okay. Good evening, all of you. And first of all, I would like to express my sincere thanks to Dr. Archana Verma ma'am and Dr. Pratik sir for making me the part of this great webinar on the management of PPH. Thank you so much. And now it's my privilege and pleasure both to introduce our speaker, Dr. Poonam Verma Shivkumar. Madam is professor and head of Obs Gyn department in MGIMS Sevagram, Varda. She did advanced training in SHRH from Uppsala University, Sweden, NTTC JIPMA, clinical skill trainers training for EMO and CMC Vellore. She is a principal investigator for PPH bundle project in Harvard University, misoprostol and oxytocin labor induction in University in Liverpool, and also co-investigator for hypertensive pregnancy in community. She's a TAG member and she has a long list of achievement, publications and awards. Today, Madam is going to have some very good insight on the topic surgical management of postpartum hemorrhage. So you are welcome, ma'am, and over to you now.
Thank you so much.
डॉक्टर पूनम, आप लैपटॉप से कर रहे हैं, मोबाइल से? ओके.
To all of you.
मॉनिटर की आवाज आ रही थी जैसे एचडी में.
I think ma'am has joined from two audios. That's why there's a lot of echo from two devices. She's joined.
Please say something.
Hello, Poonam ma'am, are you there?
A very good morning to good evening to all of you. Can you hear me now?
Yes, yes.
Yes, ma'am.
To all my seniors who are here and all my colleagues and juniors who are there, what I am going to talk to you today is the surgical management of postpartum hemorrhage. And we all know that surgical management of postpartum hemorrhage is an issue. The reason being that the patient is very, very, fragile at that moment, and giving anesthesia itself is so difficult. Please go ahead. Whenever we talk about the management of PPH, there are few things which we need to know before we go into the surgical management. One is that using an approach which is now being very, very popular is using the bundle approach. This bundle approach comes in two fashions. One is non-technical component and another is technical component. Last time in PPH workshop, we had discussed in details all about the non-technical components. So I'm not going to go into the details. However, I would just like to give you an idea of what all it is. So it includes a lot of things, which includes right from system integration, communication, referral protocols, transportation, checklist, debriefing, quality improvements, and all that. We come on to, this is just a slide showing you all that. Then we come on to the clinical component. Next, please. Now, when you talk about these clinical components, it's extremely important that we give immediate management. We do A, B, C, D, E. So now we are not believing on A, B, C, and CAB. We're believing on A, B, C, D, E. We do a rapid initial assessment, quick history and investigations. We do a primary management, which is called first response, along with supportive management. We do a refractory management and shift the patient wherever she is required to HTU, ICU, or OT. Go ahead, please. So this is, you will find a lot of algorithms written in the literature talking about how quick the management should be. Follow anything But then there has to be an emergency response team which should respond to these PPH cases immediately. Next, please. This is, the rule of resuscitation, where now we have come up with the rule of 30. So I'm not going to go in details, but I'll surely talk about shock index, which has come up very recently. I wouldn't say very recently, but people have started using it very recently, and there's a huge change in the management of the postpartum hemorrhage. Please go ahead. So this is a very small card which we are using in our facility, where we get horrible cases because we are draining the most rural area of Andhra Pradesh, MP, and Maharashtra. So this was the whole project which we did here. And we have found that using these small cards, being these cards being with the nurses, junior residents, interns, it has made a great amount of difference in reducing the PPH deaths. Go ahead. So whenever we talk about surgical management, the first and most important thing is that one should triage a PPH case in the triaging room. And what do you do here is to identify whether it is atonic PPH or traumatic PPH. A simple hand, as discussed by my previous speakers, on the stomach, or on the abdomen, sorry, would tell you whether it is truly an atonic PPH or it is something else which you need to explore. Remember that in atonic PPH, there is still some time where you do several interventions and then go ahead with surgical management. But when you talk about traumatic PPH, the instant surgery is the one which saves the women. Go ahead, please. So once you have given this medical management, Dr. Tank has said so beautifully everything about the medical management. I should not go in that part of it because he's already described it. And a lot of new drugs coming like carbetocin and all, but yet to be tested in India. Go ahead, please. After this, there are a lot of mechanical managements. Now, whenever we talk about mechanical methods, you see, they somehow come under the minimal invasive things because your hand is going inside and you're doing something. But yet, recent literature says that they should be kept under a separate heading of mechanical methods. So we all know bimanual compression. We all know aortic compression. Next. And we all know various varieties of uterine tamponade. I'm not going to go in details because this is one topic very close to my heart and I'll go on and on. My topic is different, so I'll just go quickly that these are various kinds of uterine tamponades available. It is simple, very easy to use, very cost effective, very good when you are transporting the patient for transit. Just a condom on a very special catheter, put it inside, inflate it, and by the time patient reaches to you, patient will be alive. Go ahead, please. These are various packs which have been used and very, very, popular in European countries. Go ahead. And this is something which I would like to talk. This has saved number of our women. This is non-pneumatic anti-shock garment. There have been a very big boost trial in Uttar Pradesh by UPTSU, and they have found that this is something which really, really helps, especially the women in transit, to reach to you alive. And it really buys time actually to prevent the shock. Go ahead, please. Now, after you have done medical management, you have done mechanical management, yet the bleeding does not stop. So how do you proceed and when do you proceed for surgical management? Now, when I talk about this, I have few words which I have used. Everywhere it is appropriate. Appropriate medical management, appropriate mechanical methods. Why? Because there's a habit that we give half-heartedly Pitocin, we give half-heartedly Methergin, we give half-heartedly Misoprost, and then we quickly rush because we are also distressing the bleeding, which is almost like opening a tap of water. So in these cases, be sure there are guidelines that this is the maximum dose. This is how you have to repeat. This is the instant dose. Go with those. If still your medical management fails, then you go ahead with surgical management. If women is brought in shock, please, previous slide, please. If a woman is in shock, grade 3, grade 4, and she's deteriorating, please do not wait for any other method. Keep giving medical method, but shift her for surgery. If woman has delivered or operated and she's collapsing, go ahead with surgery. Traumatic PPH, you have to go ahead with these surgeries. Please go, please, previous slide. Previous slide, please. Yes. No, go ahead. Non-availability of tools, devices, monitoring. If you don't have competence in some methods, as Dr. Tang said, do not wait. If you don't know this method, go ahead with another method, but do not wait for the bleeding to happen and then you go ahead with the method by calling some competent person and the women dies. So these are some indications where you will instantly go for surgical management. Go ahead, please. This is the WHO recommendation that surgical interventions include various forms of compression sutures, ligation of uterine, ovarian, and internal iliac artery, subtotal or total hysterectomy, and all of them aim to control PPH only when medical and mechanical interventions are failed. Now, there are strong recommendations, but there are very low quality evidences. Why? Because you can't do RCT in these cases. PPH is not something where you can do RCT. And this is why we are failing in giving the evidence. We are doing sporadic studies, but we are failing in giving the evidence to the world by using these uterine tamponades. The FOGSI, the previous doctors like Dr. Chitra Pandit and all have tried single balloon, double balloon, and so many, various varieties of uterine balloon tamponades have been used. But the problem is that RCTs cannot be done because each woman who has PPH is important for us. There are a lot of ethical issues. Go ahead, please. Now, we come on to the first management of atonic PPH, which is surgical compression sutures or surgical uterine tamponade, or what you call uterine compression sutures. Go ahead. So how do you define these compression sutures? These are the sutures which are applied externally to the body of the uterus in various patterns and involving either upper or the lower segment or both. It functions in a manner similar to manual compression so as to act as a brace to facilitate uterine contractions and retractions. And the tightening of suture also produces compression effect. Go ahead, please. Now, there's a biophysics in controlling the hemorrhage. There's a young Laplace law in which we say F 2T upon R. And this R is the radius of uterus. So if the radius of uterus will be big, the force required will be more. So whenever there is PPH, wherever there is atonic PPH, the radius increases and there has to be a compression force which is given by these compression sutures. Go ahead. Now, how do you test for uterine compression sutures? To tell you very truthfully, these uterine compression sutures are better to be taught to the medical officers. They are better to be taught to the, excuse me, please. These are better to be taught to the even the medical officers who are not a specialist. The reason being that these are the compression sutures which can be very easily put in. And when you have to test whether your compression suture will work or not, all what you have to do is you compress the two walls of uterus. If the uterus is open, the abdomen is open, take out the uterus, compress it after exteriorizing it, and you will realize that the bleeding stops completely. And then you can say, yes, this suture is going to work. Wherever you see that in spite of compression, the bleeding is continuously there, probably the suture will not help and you have to go ahead with devascularization surgery. Go ahead, please. Now, these are several. When you go into the literature, you will see nth number of sutures. Everyone has designed their own sutures, different way, vertical, transverse, oblique, and so on and so forth. But the common ones which are used, go ahead, please, are these: modified B-Lynch, Heyman, Cho sutures, Pereira suture, Gunshila global suture, which have been used by in our country. Go ahead, please. So you come on to different sutures. These are just, I'm showing you, these are vertical sutures, B-Lynch, Heyman. Go ahead. These are B-Lynch suture, which are actually used by all of us probably. And this particular, these are some pictures which are giving you an idea that from the lower lip of incision you go, come out from the upper lip of incision, go on the top of the fundus, come from behind. Go ahead, please. Then you come out again from posterior to anterior, and then you go again from on the upper lip, go behind on the fundus again, and come out from the lower lip, and you tie it. Please go ahead. So this is how you apply the suture. Go ahead. This is again the way the sutures are to be placed. Go ahead, please. This is how you compress the whole uterus, suture it, and you suture the cesarean wound if it is cesarean section. So B-Lynch suture is the one which is being used very effectively. Now there are Pereira sutures which are given transversely. Now you can see they are concentric sutures. Some of the obstetricians are of opinion that if you do these concentric sutures, you're taking care of descending branch of cervical artery, you're taking care of vaginal artery, you're taking care of low ligation of uterine, and you're also taking care of high ligation of uterine. So they work like compressing the uterines which are going up. Go ahead, please. These are Cho sutures, which are brace sutures, and I have tried it for placenta previa. They work very well. These are just brace suture. From one end, you go on to the upper, then onto the lateral, 1 centimeter, come back down again and give the suture. The whole sinus is closed. Go ahead, please. And then what you see are different variety of suture. Please go ahead. Yes, again, go ahead. So these are various sutures. Now, what is the concern of this suture? Three major things. One, they loosen. Second, there are a lot of infections seen with these sutures. And third is necrosis. There are several literature available where the uterus has got necrosed. But believe me, if you talk about the sutures where we have given here, I remember only one case out of maybe 23 who had this kind of uterine necrosis, and we had to do hysterectomy for her. So it's not for all. It's also whether patient was anemic, whether you had taken precaution for infection, and so on and so forth. So these sutures, in some scenario where women can die, they play a major role. Go ahead, please. Vessel ligations of different variety. If you see, it starts in 1950s with Waters and keep going into the internal iliac ligations. So these various vessel ligations have been given in the literature, and I'll come on to one by one. Please go ahead. So this is the surgical anatomy, which tells you that at the level of internal os, one branch of uterine ascends up, a branch of descending cervical goes down, which collaborates with the vaginal artery. And there's also an anastomosis, which is there at the level of tube coming up. So mesosalpinx, and at the cornu, you have that anastomosis. Go ahead, please. When we do stepwise devascularization, we're talking about bilateral ligation of uterines first, then bilateral ligation of ovarian and uterine artery anastomosis, and bilateral ligation of anterior division of internal iliac artery. Go ahead, please. So devascularization, of course, we all know that whenever we are doing uterine artery ligation, a chunk of musculature of uterus has to be taken along with it. There are two varieties. One is high ligation and another is low ligation. Generally, what we prefer nowadays is vicryl, by which we ligate these. And when you are ligating high, it's not a problem because it is just next to your incision. But when you are talking about low ligation, where descending cervical is also taken care of, you have to push the bladder down, and then only you have to take the suture. Go ahead, please. And so this is the uterine artery ligation takes care of most of it, but then comes the ovarian artery ligation and anastomosis. And this, go ahead, please. This is done exactly at this site. You should not take ovarian ligament, not take round ligament, but exactly the site which has shown where the anastomosis is occurring is the site for uterovarian artery ligation. Go ahead, please. This is the anterior division of internal iliac. Now I will just tell you one thing here, that if you see, there are a lot of literature, there's a video for internal iliac, but 2-3 things, key points. You have to see sacral promontory, go laterally, open the visceral peritoneum, and you will see the bifurcation of common iliac. Go and trace internal iliac, move 1 to 1.5 centimeter. Some people say 2 centimeter. And you just pick up the artery and ligate, because by that time, posteriorly, the posterior branch has already gone and it is safe. So these are few things you need to know. In the mess of blood, you may not be able to see where your internal iliac, anterior branch and posterior branches. So all what you do, sacral promontory, go laterally, open the peritoneum, see the bifurcation, look into the internal iliac, remain 2 centimeter ahead and just pick up and ligate. And that, purpose. So this is all about the internal iliac artery ligation. Go ahead, please. Go ahead, please. And how does it help? We all know that it significantly reduces the pulse pressure. The arterial circulation reduces significantly from 77 to 85%, and then you are done. Go ahead, please. Emergency hysterectomy, of course, is a last resort for several reasons like uncontrolled PPH, morbid adhesion, rupture uterus, trauma. And here also key points are that don't try to be too heroic to go for the total hysterectomy. You can even be done with subtotal hysterectomy at that particular moment. And there are a lot of literature coming, then leaving service in the young women probably helps in better sexual activities and all that stuff. So a lot of literature is coming. So it's not necessary that you have to go do total hysterectomy and kill the patient while searching for the end of it. Go ahead, please. Uterine artery embolization, all of us know it needs radiation interventional radiologist. Not everywhere it is available, but wherever it is available, you must know that there are specific indications. You should have stable vitals. The women should never be taken if she is in syncope or shock for these kind of procedures. It's a little stable vitals. You have given blood, she is stable, and you rush her to intervention radiologist for uterine artery embolization. Go ahead, please. So these are just 2 diagrams. Go ahead, please. Showing that internal, the uterine artery has been embolized. Go ahead, please. Management of traumatic PPH. I'll just tell you some simple guidelines. Go ahead. So we have perineal, cervical, vaginal, fornical, paraurethral, bucket handle tears, avulsions, and colporexus. These are various variety of tears you will find. Go ahead, please. These are some pictures. Go ahead. Yeah, go ahead, please. Now, these are the management strategies when you talk about traumatic PPH. Do not let your nurse see, do not let your junior resident see. This is a time when your senior obstetrician has to be there. There should be no delay. Never try evaluating the women in inappropriate place. We have seen people have been, doing cervical explorations in labor room, and the women, when she has been brought to OT, she has died there. Please give least trouble to the women, because we are talking in the era of respectful maternity care. Under anesthesia, if you visualize, you do a full evaluation, you decide whether laparotomy is to be done because there is some kind of colporexus, All this can be done in OT under anesthesia. So prefer doing such kind of traumatic PPH evaluation in OT so that you can do immediate repair. Blood and blood products should be with you, and these patients needs to be very critically monitored post-operative. A little about retained placenta, placental fragments, inversions. Here, this is, as Dr. Tang said, that this is the most difficult case of secondary hemorrhage. Most difficult because, you tend to perforate, you do a lot of things here. So MVA is supposed to be one of the very good technique here to take out the fragments. MRP, of course, has to be done if it is a retained placenta, and various techniques of inversion with seniors have to be there. You have to ensure, not that juniors cannot do, but at this moment, you need a moral support. And if you have seniors around you, 2 or 3 people together can really do a good job here. Go ahead, please. Coming on to the last part of my talk, there are several recent advances coming up. And I would say that please look into the literature. Paniker's vacuum suction, which is a hemostatic device for treating PPH. They have treated 40 women. None of them had problem. And believe me, I tried it for 2 of my cases where, she was so bad that I didn't even know that if I shift her from my triage to the operation theater, she may die. I only tried this and both of them are absolutely fine. And this is just maybe 2 days or 3 days. I have tried on one patient and maybe another a month before on one patient. And so what I want to say is that these recent advances, one can try in desperate situations and see how they work. So this Paniker's vacuum suction has worked very well with me. So I strongly recommend that this should be seen. Go ahead, please. And this is another important thing I would like to tell you, that there are some, Dr. Pillai has created some paracervical clamps. We got it when there was some conference. And we are using it whenever there are huge cervical tears which are bleeding and it is difficult for us to see. We just put these 2 paracervical clamps in the vagina because they are made in such a way that they take care of the area where the cervix attaches to the uterus. So at the extreme top, you put these 2 clamps. They also reduce significantly the blood loss. So friends, what I want to tell you is that surgical managements are difficult, but these are extremely important because they are the ultimate things. Few things are that internal iliac artery is becoming a lost art now because most of you are going on for the compression sutures and all. But I yet say, learn internal iliac artery from your teachers. The reason being that if you do not know that, you will be hysterectomizing number of times the women who are primigravidas or who do not have baby, the baby has died, and so on and so forth. So my strong recommendation is that all these methods should be known by the obstetricians very well. Go ahead, please. I thank you all for your patient hearing. I'm really sorry because being in COVID, we're not able to, it's our COVID posting going on. So we are not able to, fix up the computer and also I'm sure you'll excuse me for that software.
No. Dr. Poonam, it was marvelous and surgical management. Oh my God. Let the Pratik say a few words, then I will say.
I think it was a very good, accurate summarization. In half an hour to cover the entire surgical management of PPH is a tall task and it's a very difficult task. I think Madam has done more than justice by covering so many different aspects and covering all the wide gamut of options which are available to us. The problem is that all of us have knowledge. To approach it systematically, to present it in a lucid fashion, and in such a way that the practitioner is able to remember it at the time of an emergency when most of us are functioning at a spinal level. That is the art of public speaking, and I think she's more than equal to that task. Thank you so much, ma'am.
Really, really very good, Dr. Poonam. You have done real justice to the topic and surgical management. What I think everybody should think of small things, uterine inversion or how to manage cervical tear, extended posterior vaginal tears, and those bad cervical tears involving broad ligament hematoma and then suturing outside only and then leaving the patient and patient going into shock, and to learn internal iliac artery ligation is really, really very, very important. Sometimes it's a life-saving procedures. So that unless and until we listen to all those people who are doing, like she has told, the panickers cannula. So I think it should be in each labor room, and let us practice also. Everybody, these are the very small things, but life-saving. मैकेनिकल स्टार्ट विद द मैकेनिकल, जैसे ही आपने देखा मेडिकल तो चलाई दी आपने, मेडिकल ट्रीटमेंट स्टार्टेड, बी प्रिपेयर्ड फॉर द मैकेनिकल, बैलून लगाओ और prepare the OT, prepare the team, and in the meantime don't let don't wait more than 20 minutes. I think it takes time itna sab karke. How to shift the patient from labor room to OT is also very, very important by telling the patient, because that is act fast. That is the only thing we can do. And a senior experienced surgeon is a must, and along with you, like bladder injuries and also to tackle with. Surgical management is really, really very important, but sometimes too tough. When there's a diffuse bleeding, you are not able to see anything, and it is even hysterectomy is also not all that easy. So many things.
Thank you so much. Thank you, Dr. Archana, for inviting me. Thank you very much.
Ab kya?
I'm sure the audience must have been benefited a lot by proper management, medical, surgical, and all the strategies of prevention and all. And I think we can start the question answer session. Dr. Pratik, can you take over?
Dr. Shazia, have you noted the question answers, Dr. Pratik?
Yeah, there are some questions in the Q&A box, and I'll just
Sir,
read
is
them
there?
out.
अच्छा, किसके लिए है बता दीजिए.
So the first one is regarding, do we need to take consent for hysterectomy for every patient? Now, this is a very valid question because the patient is bleeding, is on table, is in a case of hypovolemic shock. Probably she is not fit to give consent, but by law, we need to have consent of the patient on paper. Dr. Asha Jain, madam, I think in your talk, you had briefly addressed institutional policies and medico-legal aspects. I think you're the right person to talk about this.
I think, in the complication section, when we are taking a consent, because for a valid consent, the consent has to be taken when the woman is not in labor. So the basic thing is that in her last antenatal visit, if she's a high risk case, I cannot say about every case, but any high risk case or in your prediction chart, if it is coming as positive, then everything has to be explained and documented. It has to be.
There's a comment from Dr. Alka Kuthe in the chat box, and she says very correctly that an emergency life-saving procedure does not always require the patient's consent.
In emergency, it does not require.
This is
but
a fact.
The thing is, you need to prove that it's an emergency. And for that, again, all your documentation is the only thing that is going to save you.
Correct. That is always the case. And of course, you need to ensure that your documentation is complete, that at least you have made an effort to speak to the patient, to the relatives, take an informed consent, and wherever possible, try and take a high-risk consent before starting the surgery in cases where you expect that there is going to be PPH and you are going to land up with complications. We've already tackled the issue of where you expect regarding the 4 T's and all that. So we'll not repeat that. Let's go to the next question. And this is from Dr. Shubhra Agarwal, and she's asking, can we use tranexamic acid in active management of third stage of labor? I think this was covered briefly.
It has to be. It has to be. In cesarean section, not in normal labor.
Correct. Absolutely. The next question is from Dr. Ratna Sharma, and she is asking, there's a primigravida who's had prolonged labor. She's delivered normally with an episiotomy, but had PPH. Uterus was contracted with a loose cervical area. Obviously, the cervix is dilated and there's no tear. So what would you like to do in such a case? Somebody else can take this up. I don't know if Dr. Jaydeep Tang sir is...
I think he was there. Dr. Jaydeep sir, are you there?
Maybe he's busy with the patient. I may not be able to respond to questions. So anyone can take this up. Neharika ma'am, do you want to take this?
Episiotomy, as I said, gives, it's responsible for 4.7% of the cases of PPH. So a good repair of the episiotomy properly with a finger in the rectum at the end to confirm that there's no hematoma in between. That is necessary and that should take care of it.
Okay, I think here the question was that episiotomy is normal, everything is okay. It looks like an atonic PPH. Maybe there's a slow trickle which is happening. And we talked about this, that sometimes we can underestimate the actual blood loss in these patients because we are seeing them maybe once. We're not seeing them repeatedly and over a period of time. And there's a slow
Yes,
trickle.
it
And when you
is.
finally diagnose it,
Yes, it is at this time only the experienced doctor, gynecologist, and that bimanual compression and that is really needed because episiotomy sometimes apparently looks normal and there can be sometimes posterior bleeders also or atonia inside.
Maybe a good examination under anesthesia will also be very helpful in such cases to actually
Very true.
explore the canal.
And if you have the entire team that is activated once the issue is diagnosed and everybody goes through systematically all the different steps, probably you would be less likely to miss out the different causes which you don't always think of.
Yes,
To
Dr.
add
Pratik,
on,
very
sir,
rightly, Dr. Jaydeep Tang very rightly said, make it very simple. And if you are alert and aware, especially Sara problem generally tab aata hai when you are too much tired and doing so many deliveries and at 11, at 12 or 1 a.m. in the morning, and you are again, अच्छा ठीक है थोड़ी देर 2-3 घंटे बाद देख लेंगे, and at that time staff also goes away and the patient के attendant अपना मजा कर रहे होते हैं, बच्चा हुआ है मिठाई खा रहे होते हैं, सो जाते हैं, घर चले जाते हैं. That is a time.
To add on, ma'am, I would just like to say that these are the cases where you see uterine balloon tamponade placing helps a lot. The reason being that we have done it in previous scar cases also. This is a low pressure and high volume device. It does not rupture the scar, which is a major fear. It's a very low pressure, high volume device. And once you put this, you buy time for the coagulation factors to come in and act and reduce the blood loss significantly. So wherever you see the continuous small trickle, which could become bad later on, probably these mechanical methods help us a lot along with the medical methods, and they will change the whole scenario.
Thank you, ma'am. We have just a couple more questions. And since Dr. Archana Verma talked about this at the beginning of the program, there's a question from Dr. Surya Kumari, who is asking, please explain about obstetric shock index. How is it helpful in managing PPH? Ma'am, you'll need to unmute.
Yeah. This I will I will take this question. Shock index, Dr. Poonam has also told. And since I am talking, it is actually heart rate divided by the systolic blood pressure. And this heart rate actually all is the best thing. Even if you see the BP may come normal, but though that low volume pulse and that tachycardia, very typical of the shock, even by just feeling the pulse, you can make out. And when you do that heart rate upon systolic blood pressure, then it is more than 0.7, and that means patient is going in shock.
Thank you. Thank you so much, ma'am. And there's a question from an anonymous attendee about, please elaborate about the vacuum suction device in PPH. I think Dr. Panikar's cannula was explained in quite great detail. So for the benefit of the audience who might have missed that, Dr. Ma'am, would you like to repeat that?
Yeah, I would. See, there is a very special suction device which is there. These cannulas are very cheap and very, very affordable to everybody. They are attached to a suction machine, and whenever you have heavy bleeding or clots coming out, you have to just put this cannula and the suction is put on. It's almost like the suction what you have for your doing suction evacuation in case of molar pregnancy, because suction evacuation for abortion cases for taking out the retained products of consumption is different, and the suction evacuation for the molar pregnancy is different, where you want a very quick release of these products. So the similar thing happens here. And here, the moment you see that the blood starts trickling out here, the uterus contracts. We initially, had a fear that, oh my God, there'll be too much of blood loss in this, all the sinuses will open, which are blocked, and maybe she will lose more blood.
Hello.
So, but then to me, it worked twice. So I strongly recommend it.
Thank you, ma'am. I think there's one more question, and you addressed this in your talk again, but just for the sake of the audience, I'm taking it. It's from Dr. Seema Saxena, and she's asking which is the best suture material to be used in B-Lynch and other compression sutures. Also, regarding the needle specifics, what is the size and curvature that you recommend?
See, nowadays, there are very special needles coming with Vicryl. So we use here either 1 Vicryl, people have used even 1-0, but we are using number 1 Vicryl, and that comes with the needle. So you don't have to specify needle size or anything. You ask one number Vicryl needle, Vicryl with needle. Of course, it comes with needle, and it has, it is little thicker. So the fear that it will, completely cut the uterus and all is not there.
And of course, the original papers talk about straight needle and chromic catgut. I don't know if chromic catgut is widely available anymore.
It's not available, and the thing is that you have no time at that moment, to put
and thread a needle,
thread the needle, and do these things. So these Vicryl curved needles are working very well.
Absolutely. So for all practical purposes, in most OTs, wherever you go, even if you are called as a surgeon to assist by another of your colleagues, probably they will already have Vicryl in the OT, or you can just pick up one and carry it with you. And that is something which you can use very easily and quickly. You don't have to wait for the chemist or the relative and so on and so forth and delay the treatment any further. One last question is regarding Dr. VP Piley's aortic clamp, and I think it was not mentioned, so I'm just mentioning it here for the sake of completeness. Professor VP Piley is, of course, a legendary figure in obstetrics in India, and of course, we know that the state of Kerala has the lowest maternal mortality anywhere in this country, thanks to the rigorous protocols which the Kerala Federation has instituted, and all of us can learn from them actually. One of the aortic clamps which Professor Piley has devised is used as an aortic compression device, and in an emergency when there is blood pooling in the peritoneal cavity, you cannot identify the site of bleeding, probably just for a short period of 15 to 20 minutes, to ensure that you are able to identify the site of the rend in case there's a traumatic PPH and take corrective measures. This is one of the instruments that can be used. So for the sake of completeness, I'm just mentioning that. I think that concludes
and
the
this
Q&A.
one point is that even though he's Dr. Piley, the clamp goes by the name of Pillai clamp in Maharashtra. It goes by that name, and the clamp is I have tried it twice. It is just that you clamp it like when we are doing myomectomy, what we do is we clamp the uterine arteries for 15 minutes, open it for after 5 minutes, and then it's something like
That's
this.
the vaginal clamp,
Yeah. But here it is a vaginal clamp. You clamp it. At that time, the blood will significantly reduce. You will be able to identify everything, and you'll be able to repair. So those clamps are extremely useful.
Thank you so much, ma'am. And that concludes the Q&A session. I think Dr. Archana Verma is on the phone. I would request the moderators to please take over. Dr. Alka Sethi and Dr. Shazia, you've done a fantastic job today. Thank you so much. Please go ahead.
Thank you, sir, for coordinating and moderating the session so well. So I think, Dr. Alka, we can conclude now by the formal vote of thanks.
Yes.
Dr. Alka?
Yes, with Dr. Archana's permission, Dr. Pratik has already given this green signal.
So we can conclude by the formal vote of thanks. So I express my gratitude to Dr. Archana Verma, madam, for a wonderful academic session. And I know everyone must have enjoyed the whole program. And it is a testament to madam's organizing skills in bringing everyone together and making them participate. And these webinars are a boon nowadays as we get to hear from so many people at one point of time. And I would like to thank our chief guest, Dr. Alpesh Gandhi, sir, for his blessings. I thank our conveners, Dr. Madam Archana Verma, madam, for framing a wonderful program. I thank our co-convener, Dr. Pratik Tambe, sir, who is always there to support us and guide us in all our academic activities. Thank you very much, sir. I thank our chairpersons who graced the occasion and gave very valuable inputs as well. Thank you, Dr. Rajendra Nagarkatti, sir, Dr. Neharika and Dr. Saba for a wonderful job you have done today. I thank our eminent
for Dr. Neharika को invite करो. हो गया? मैंने शायद सुन नहीं रही थी.
मैं यहीं पर हूँ.
अच्छा.
नहीं हूँ.
We are just having closing comments from everybody, ma'am, and then a vote of thanks.
I'm here only.
And I thank our eminent speakers for a very informative and elaborative talk on PPH and brushing
Happy
our
Diwali
knowledge.
वाला हो गया message? I missed, I think.
नहीं अभी time है उसके लिए.
अच्छा.
Picture अभी बाकी है.
We thank our speaker, Dr. Jaydeep sir, Dr. Asha Jain madam, and Dr. Poonam madam for a wonderful talk and brushing our knowledge today. I thank my co-coordinator, Dr. Alka Sethi madam, who is always there as a source of motivation for us and coordinating the program so well. I also thank our academic partners, Jackson Pal, Mr. Vipin, Deepika, for coordinating the program so well and helped us in organizing this big event. And it was a great privilege and a matter of prestige to be a part of such a big event. Thank you so much for all joining. Thank you so much.
I offer my special thanks to Dr. Mandakini Meg, Chairperson ICOG, and Dr. Parag Biniwale, Secretary ICOG, for being charitable enough to grant us one ICOG point. And I wish everyone a very happy Diwali and happy New Year. It's called Besta Varas. Dr. Alpesh is not there, but we call it Besta Varas because I'm from Ahmedabad. I'm from Gujarat. And we wish Dr. Deepika a speedy recovery. She was instrumental in bringing this show, this webinar. But due to some unforeseen circumstances, she's not well. So we pray for her speedy recovery. I think Dr. Neharika, I invite Dr. Neharika to sum up. I think.
Thank you so much, everyone. And I think it was a wonderful session. Special thanks to Dr. Pratik for coordinating the session and was with crisp question answer session. And I would just like to end it with a small quote. It's one of my favorite quotes and I've been using it for the past 6 months. I think COVID has taught us a lot of things, especially on introspection and a positive change in mindset. So I always say that this world actually now needs peacemakers, storytellers, social workers, makers, restorers, happy people. And with this quote, I wish you all happy festivities.
On behalf of Jackson Pal, makers of JP Tone Iron Syrup, enriched with zinc and vitamin B, say no to anemia, Cyclorex CR10, Endorec tablet containing 2 mg Dynogest for endometriosis associated pelvic pain. I thank all the experts present with us today. We are truly appreciative of the presence of all the attendees. With your unending support, we hope to go a long way in knowledge sharing. Thank you so much.